This is the Therapy Chat Podcast with Laura Reagan, lcsw-c. The information shared in this podcast is not a substitute for seeking help from a licensed mental health professional. And now, here's your host, Laura Reagan, lcsw-c.
Hi, welcome back to Therapy Chat. I'm your host, Laura Reagan, and today I'm really excited to be speaking with someone who I've been following and reading about for a while now, Dr. Rachel Rubin. Rachel, thank you so much for being my guest on Therapy Chat today.
Thank you so much for having me. It's an absolute pleasure to be here.
Thank you. And I think it's going to be a very interesting and informative conversation for everyone. So I really want to get into talking about the work you do. But before we start actually talking about it, can you tell our listeners a little bit more about who you are and what you do?
Yeah, absolutely. So I'm Dr. Rachel Rubin. I'm a urologist, and I did a fellowship in something called sexual medicine, which means I really do four things, but I do them really deeply and well. I deal with issues of libido, arousal, orgasm, and pain. And we treat everybody, no matter what genitals you have. We help you drive them better in whatever way you want to. And I did a fellowship. Not a lot of people do sexual medicine fellowships, and there really aren't many fellowships available to deal with female sexual function. And so really there's 27 that acknowledge men's sexual health and really only one that deals with both male and female sexual health. And it's changing slowly, but a little bit slower than any of us would like. And so I practice in the Washington, D.C. area. I opened up my own, I've been practicing for a while, but I opened up my own private practice in about 2.5 years ago. And it has been the joy of a lifetime to take care of people and to do so in what we call a biopsychosocial approach, which is why I love being on this podcast, because I can't do my job without all of the wonderful mental health professionals, the pelvic floor physical therapists, and really whoever I need to bring in to be that pit crew to help our patients maximize their quality of life, because that's the most important thing that we do. And so in my work, I know it's a long-winded answer, but in my work, we take a lot of time with people. So our new patient visits are anywhere from an hour to what I want to be is 2 hours in the future, because I really want to connect deeply with my patients and understand what are their goals, what are their stories, what do they want, what do they care about, and then spend the time educating them of what does the toolbox actually look like.
That's fantastic. And spending an hour with patients is incredible. Having 2 hours is almost like unfathomable. And the fact that, oftentimes we have to go into private practice to be able to create the way of practicing that really fits what we feel will be best, what we know will be best, because there's so many factors preventing providers, clinicians of all types from being able to do deep, in-depth work with people. But that's what's needed. And I think it saves ultimately, for insurance companies, it's all about dollars, and it saves money to have a holistic approach that really addresses people's needs on many levels, rather than people trying to find all these different specialists all the time and get someone to listen to us, especially for women. It's really hard to get medical professionals oftentimes to hear us about what our concerns are and to not be dismissive based on maybe their lack of knowledge and understanding about what options are available. And I certainly experienced that myself when I started going through perimenopause, which was like 10 years ago. And I'm still in it. And, my doctor's response to my questions was, well, you're getting older, and maybe you can lose weight. And that was pretty much it. So I'm really grateful for what you're doing, and the fact that, as you shared with me before we started recording, that you're expanding your practice so that you have more providers available to meet the needs. Because if you have a body, these issues are going to come up. at some middle age point in life, usually. Not always, but usually. So, how did you find doing a fellowship in sexual medicine and the one that included female bodies?
Yeah, I was very lucky to find mentorship. It's funny, going through middle school, high school, my group of friends, we talked about things. We talked about genitals. We had friends who had issues, who couldn't put tampons in, who couldn't orgasm, who had, challenges, pelvic floor challenges. We knew what the pelvic floor was, even in middle school and high school, which I didn't realize was unique, because then when I went to med school and sort of went on, I realized, no one's really good at talking about sex and sexuality and sexual health. And I know it's not perfect for everybody. And so it became an interest of mine. And again, urology was a really wonderful space where you could take care of everyone. When you're a urologist, you're board certified to take care of all genders' genitals. You're just not taught to be as good at dealing with female genitals. So that's something we're working towards, helping that equity. But it really, it became really nice to be able to help everybody. And then I found my mentor, this brilliant human named Dr. Irwin Goldstein, who sort of really pioneered the field of sexual medicine for all genders and has really done really important work in the field. And so it was a very wonderful opportunity to get to work with him, in that fellowship.
That's amazing. And yeah, certainly, I think everyone's talking about sex in some ways as teens and adults, but knowing what the pelvic floor is, I think I first heard about it when I was in my 30s. I heard about Kegels, but, now I understand the value of pelvic floor physical therapy. I'm recommending it all the time. So, you mentioned, I definitely want to talk about menopause and what's available, but some of the things that you mentioned are working with libido, arousal, orgasm, and pain. And as soon as you said that, I thought those are 4 separate things that all might be sort of like mysteriously blended together and a problem that someone's having. It's like, I don't exactly know what's wrong or what to call it. So can you kind of explain what those are and how they factor into the work you do?
Absolutely. And, part of why I love my job is actually I get to take very smart people, right? And I get to explain to them very basic facts about how their bodies function and work, and that it's not unicorns and magic, that it is actually biology, it's anatomy, it's nerves, it's muscles, it's arteries, it's physiology, it's the fight or flight system. It's so incredibly fascinating. And so I do a lot of educating, which is why my visits are so long, because if a person doesn't understand what's going on with them, there will not be good outcomes. And it really is that education that allows them to then see the toolbox and say, oh, I want to try that one. I don't think I'm ready for that one, but it's nice to know it's there. And I have found that when you give people knowledge, they make excellent healthcare decisions for themselves, right? Excellent. Like, I don't tell people what to do. I give people the menu, and they have, through their knowledge and their research and understanding, they get to decide sort of what they want to try. And that may change. And so, when you talk about things like libido, arousal, orgasm, and pain, many people, when they have sex, they don't really think about them as sex. They just think of sex as this thing, but everyone has sex differently. Everyone's sex looks different. What people want actually looks different. And if you don't ask them, no medical provider has ever asked me detailed questions about my sexual health. And so I know, and I wear a clitoris around my neck, so everybody knows what I do for a living, but nobody's ever asked me, right? And so that means no one's asking anybody. And so it really is important, not just do you have sex. When I went to med school, right, they taught you to say, do you smoke? Do you drink? Do you do drugs? Do you have sex? Do you have sex with men, women, or both? That was all we were told to ask patients. And that is insanity, right? And so instead of doing it in the vice category of like, oh, you're doing bad things like drinking, smoking, and having sex, we try to bring it out into what we call the review of systems, right? Do you have headaches? Do you have any GI issues? Do you have any bladder issues? How's your libido, which is your interest in sex? What is your brain? Does your brain want sex the same way that you used to? Do you have, sort of, tell me more about that. Do you want sex on its own, or do you have to someone else initiate in order for you to want sex? And are you bothered by any of these issues? arousals like erections, right? So either the clitoris or the penis sort of arouse and get larger. The lubrication that comes with arousal, right? Understanding it's the sort of the physical feelings, although there can also be mental feelings of arousal. You feel your body engorging and lubricating. And then there's orgasm, which is a whole other separate animal. It is a whole other sort of a wide open space where there's not enough research, but it is essentially sort of a reflex, just like a sneeze. It's a buildup and a release of pleasure. And everybody orgasms also in sort of a slightly different way and feels it slightly differently. And if we don't ask, we just assume everybody does everything the same way. And so then there's that orgasm. And for men, there's the ejaculate, which is actually also a separate phenomenon from orgasm. And then pain is pain, right? You can have pain anywhere. You can have pain in your clitoris. You can have pain at the opening of the vulva. You can have deeper penetrative pain. You could have penis pain. You could have testicle pain. Pain can happen anywhere and can really affect sexual health and quality of life. And as you said, there is such a Venn diagram of overlapping in these conditions where unless I joke, I call myself Dr. Rachel Rubin, sex detective, right? Because what I'm doing is I'm diving deeply into these issues to try to understand it. Can we understand it from that biology and then of course the psychosocial aspects, but can we understand all of it and explain it? Can we come up with a hypothesis of what might be happening? And so that's kind of my role in kind of breaking down libido, arousal, orgasm, and pain. Does that make sense?
Yes. And it's so helpful. And, for some people who are listening, this might be like the most sex education they've ever had because I remember talking to a colleague who was a female therapist who was speaking about, I think this person was in their late 50s and they were talking about like a lack of personal understanding about orgasm. And it just made me realize how I was raised in the 70s, and I think I got most of my sex education because my mom had a subscription to Ms. Magazine. And so I used to read that and Cosmopolitan, like when I was in elementary school. So it was over my head, but it was also just plainly laying it out there. Like, this is how it is. And it was actually really helpful that I had that information because it was like a way of knowing about my own body and my own experience that nobody was talking about, including periods and things like that, if I hadn't had that resource. So it lets me know, like you said, if I'm not hearing about it, other people aren't hearing about it. So this is just really valuable. And something else that you shared really made me want to ask you some different questions, but I would like to ask you, if we can, like I said, I want to talk about menopause, but I really want to also ask you if we can talk about sexual trauma a little bit and how that may play in. Because when you said it's a fight or flight system or it's part of the fight or flight system, I was like, oh, if she knows about that, I've got to ask because as a trauma therapist who specializes I started my work in the field working with survivors of sexual violence. And that's been over 20 years. I've really specialized in that work. And I see the ways that trauma responses can show up in what my clients share about their sexual lives and their feelings about sex and sexuality. But I've yet to encounter anybody who could really explain to me kind of some of the medical and physical aspects of it in the realm of that whole trauma lens. Like, I can figure some things out from my own knowledge, but I really want to ask you, when you said it's part of the fight or flight system, can you say more about that?
So it's sex is in orgasm in particular. It's one of the most fascinating sort of nervous system events, right? So you actually need to be relaxed to get an erection. So erections, whether it's the clitoral erection, arousal, or the penis erection, it needs to be in a relaxed state. Sort of that's why morning erections happen and middle of the night erections, because you're asleep, your parasympathetic nervous system is going, you are at your utmost relaxed state. And then, but orgasm, right? When you're really into the sexual event, your heart is racing, your blood pressure is increasing. You actually kind of increase this sort of a sympathetic response in order for that buildup, that explosion of orgasm, and then you kind of go back to relaxation. So it is this dance that is being played between your excitation and your inhibition. And in fact, you actually need the inhibition to make it so you can handle more stimulation, because a lot of, if you look at sex, it's actually very almost painful looking. You can see people's orgasm faces and they look like they're in pain. And there's been research that's very interesting, whereas if you poke someone with something sharp sort of during an orgasm, they don't feel it. They don't feel the sharp thing because they're in this altered state. They don't feel pain the same way. So if you have any change in your system, right, where you can't overcome that pain response, or that you are too much cortisol going on, or there is that trauma, you may not be able to get to that zone of, that sort of pleasure area. And so it really becomes understanding the biology. So trauma is biology, right? You've had many people on your podcast that talk about the biology of trauma, and cortisol and adrenaline and all of these things are so important to your nervous system, your inflammatory pathways, and all of that can affect your sexual health. And so I really hate the sort of, well, that's in your head, right? Because your head is a huge biological part of your body that is constantly making neurotransmitters and hormones that affect how the rest of your body works. And so again, the more you can sort of really understand and then people who have had trauma also have many other biological things that can cause severe sexual dysfunction. So my issue with my colleagues who just send everybody to mental health professionals frustrates me, because y'all are not looking at the genitals, right? Y'all are not looking at the lab values and the nerve pathways and doing sensory testing and really trying to understand the biology, because you've got enough work to do with all of the psychosocial issues going on. And I rarely find someone who is just a psychological cause or just a biological. It doesn't exist, because we're a system. We're a system. We're a computer. And so I always think of it like the pit crew. Like, you actually need to sort of address multiple areas if you're going to have sort of that maximal optimization of your quality of life. So trauma is not all one thing. And I think you have to have someone who's willing to look at it from multiple angles and also really willing to work with you on each part of it. And so something that frustrates me is when, when the biology gets dismissed and ignored, when it gets, when someone, as soon as someone says, and I find patients don't bring up trauma because they don't want me as a medicine provider to do what every other medical clinician has done and just say, oh, it's all trauma. Go see Laura. She's the best. Instead, what I have done in my practice is I get the whole story and I let the patients talk for a very long time, which is why my visits are so long. And then I ask very detailed medical history questions, social history questions, relationship questions, family, ask all sorts of questions. But then at the end, when I'm sort of done with all my millions of questions that I've added over the years, I also ask them about their support system, because I find people with a support system do better with people without a support system. That seems obvious, but it took me a while to add that question in. But I always finished with this question that I developed over time. And I said, okay, here's my last question. Totally fine if the answer is no, but I'm just going to throw it out there. And I ask everybody this. Is there anything else you want me to know in your story, either cultural, religious, or trauma related, that you think is either relevant or you want me to know about today? Right? Because I just got done asking them a million questions, and I just leave the door open right at the end of like, I'm here. You don't have to tell me now, but I'm always interested and curious, and nor am I going to say that that's the reason for all of the other things, right? And I have found that patients, this won't surprise you at all, but I've had patients where we've worked together for 5 years before I get sort of a trauma story that would blow, someone's brains out just to hear. And it takes people time. And so as long as you continue to show up and you have that like sort of open door, I think it's really helpful part of the journey for the patient.
Yes. And right. It's not ever just one thing. That's the thing. When we are working with someone on their trauma, we're referring to pelvic floor PT, medical follow-up, all kinds of different things. Craniosacral therapy, there's so many ways to address aspects of how our experience is presenting at that time. And I don't think any of them can really be isolated. They all are interplaying together, you know?
And I think it's important, something I try to teach my medical community is 10 minutes is not enough time to deeply connect and understand someone's issue. It's not, right? I am not a very complex person and nobody can understand me in 10 minutes, right? It's not possible. And I think, doctors get frustrated and say, well, if it's not an easy problem, that's a crazy person, or, oh, that's too complicated for me to. And I think what I really want to instill in your listeners is really this understanding of like, you deserve comprehensive care from people who can understand complexity, because people are complex and you are a complex person because you're a person and you deserve to be valued and taken seriously in all of these aspects. So just because you're quote unquote complicated or you have a trauma history doesn't mean you don't deserve someone really taking the time to really understand the biology as well.
Yeah, I would even argue because someone has a trauma history, they deserve more time and space to be able to explain what they need to explain, or to be able to feel safe enough to speak about what they need to share.
And I ache because it is a challenge. As we all know, it is a challenge in this very extreme broken system that we have found ourselves in. And there is no obvious solution of how to fix it, but it's pretty broken.
I agree. And I'm glad that you are, this is part of changing that, is to educate people about even that there could be other options. So even other fellow medical providers who don't realize that maybe they could be practicing a different way and they think that the 10-minute paradigm is the only option. So, can you explain about how, and feel free to say that's not really in my knowledge base or scope of practice, but, how the pelvic floor and the fight or flight response work together?
Yeah, it's pretty simple. It feels simple, right? It's from this basic thought of, if you're about to put your hand on a hot stove, right? If I say, here, I'll give you $1 million. If you put your hand on a hot stove for 5 minutes, right? The stove is on, fire's going, put your hand on there for 5 minutes. You're not going to do it, right? Even if your brain is saying, I could really use $1 million right now, so I'm going to really try hard to do it, you would never do it. Why? Because your body is going to pull away immediately. Your muscles are going to pull away as quickly as they possibly can. Your arm is going to shoot back, right? You cannot plan it. You cannot tell your arm, don't do this. You cannot have a conversation with your arm. Your arm is not going to let you touch that hot flaming stove. Right. And so that's essentially the fight or flight response. And so if you have a trauma history where something horrible happened with your genitals and you don't have the language, the words, the knowledge, or the processing to move forward and to not let that affect you, well, your genitals learn. They remember the pelvic floor is a bowl of muscles and they're there to protect you. So this bowl of muscles is sort of keeping all your organs in. It's making sure you don't, pee when you don't want to, or poop when you don't want to, or fart in public or something like that, right? Your pelvic floor is always working. It's also responsible to relax so that, intimacy can happen. It's there to contract and relax when an orgasm is happening. So your pelvic floor is doing an enormous amount of work, and many of you have never even heard of it before. And so we do a lot of things to make our biceps happy. We do bicep curls. We do ab exercises and crunches. We do all these things to help our muscles, and nobody talks to us about maintenance and support of our pelvic floor. Now, Kegel exercises are only a very, very small part of the pelvic floor. And probably if you're someone with a pain or trauma history, is the opposite of what you want to be doing, because a strong, right? So like a tight muscle doesn't mean a strong muscle, right? A muscle that is fatigued and it's in spasm is not a strong muscle. And so we see a lot of people who have things like urinary leakage, pain with intercourse. A constipation is a huge one. We see so many people with constipation, and it's these muscles that are way too tight. So if you had trauma where you have cortisol and you are constantly in a fight or flight situation where you're running, right? Think of contracted muscles. Your muscles are tight. And if your muscles are contracted for years, right? It becomes pretty weak and spasm-like, and you feel a burning pain. And it's not always pain. Sometimes it's burning. Sometimes it's urgency. Sometimes it's itch. We see people with horrible pelvic itch, which is can be due to nerves and muscles as opposed to, sort of a yeast or dermatological problem. And so the pelvic floor is just like any muscle. It is responding to the nerves in your body. And if the nerves in your body are heightened or really sort of jumpy, then your muscles in your pelvis are going to be the same way. And we see a lot of overlap in people who have jaw pain, right? And again, people hold their tension in their jaw and they hold their tension in their pelvises. And because we don't teach people this language, right? They get told they're crazy. They get told, oh, there's nothing to do. And they go to the dentist or the jaw person or the ENT and they get told there's nothing to do. There's nothing wrong with them. They go to the doctor for constipation. They get put on medications because we don't teach doctors how to do this. So your dentist never learned about your pelvic floor and the muscles. Your GI doctor doesn't know what to do about. They don't talk about pelvic floor. It's a mess, and that's why I do things like podcasts and yelling and lots of social media, because if I can change one person's mind, right? Or I just saw, oh my God, speaking of menopause, I just saw a GI doctor on Instagram talking about the perimenopausal symptoms, GI perimenopausal symptoms, right? Same Instagram. I saw an orthopedic surgeon talking about perimenopause and orthopedic surgery. I said, the world's changing, right? Because it is not, more people are talking about this. And when they see us talk about this, they want to learn and say, oh, that's really interesting. How can I change my field? And that's when you train a diverse group of people in a subspecialty, because only men used to be doctors. And so we have a whole, we have a lot of work to do to sort of change what medicine studies, because now there's kind of women who are there being like, wait, why don't we know this about women? Why haven't we studied this? It's because no one's bothered to ask the questions.
Yeah. Thank you for what you said. And again, what you do, and the jaw pain and pelvis connection, that being spoken out loud, because I just have to say, sexual violence is so common. And so therefore sexual trauma is so common, and trauma is so common, whether it's sexual or another type. So I want to say, and I want to sort of clarify something I said for anyone who's listening. You may not have experienced sexual trauma, but your pelvic floor could still be contracted for the same reason, because you have trauma and your body is doing a fight or flight reaction, even though it's not related to sexual experiences.
It's so important. And I think there is so much sexual trauma out there. I think there's about 1 million times more amount of medical trauma out there. So think of, I had a speculum exam go wrong, or I had a doctor's visit that didn't feel right for me and it felt uncomfortable, but I had no way to speak up. We see tons of medical trauma, right? Where there was maybe not a story of a horrific trauma, but it was a speculum exam gone wrong and the pelvic floor was just like, nope, we're not doing this. Or I tried to put nope, we're not doing this. And sometimes there's a lot of times there's sort of a biological reason why that happens. But again, trauma is in the eye of the trauma is it. And I see so many patients who minimize their own traumas because they say, well, I've heard of much worse things happening, so my trauma is, doesn't matter, or it's not important. And what I've learned over the years is your body doesn't really, it doesn't really care. Pain is pain. As Oprah says, pain is pain.
Yes. And if I could tell you, if I had a nickel for every time that someone has said, really, this is trauma, but so many other people have had it so much worse. That's literally what every single person I work with who has trauma says. And I tell people that every time. It's like, that's what That's what a trauma survivor would say. So actually that kind of validates that, yes, your experience was traumatic. And then there's a part of you that needs to shut down that awareness because that's what you had to do to survive that moment. And now, it leaves you confused. Was it really that bad? I'm not sure if, it really fits into that category. So thank you for saying that. And medical trauma, it's about loss of control over your body. So even things that may have happened during a planned surgery, it's still, you were unconscious and something was happening to your body, and that could be experienced to your system as totally overwhelming, traumatic. And yet, because it's outside of your conscious awareness, because it happened when you were under anesthesia, you can't really say this happened, that happened, and that's why I feel this way. So that's one of the things that makes it just so confusing after experiencing trauma. So I'm really grateful for how clearly you're explaining these things. I'm also going to say that a lot of people who are trauma survivors have trauma reactions at the dentist when, they have a loss of control over their bodies and someone's inside of their mouth and they can't do anything. And there could be scary or painful things that are happening. Especially sexual trauma survivors tend to have flashbacks and relive their sexual trauma experiences during that time. So I think it's really important for all healthcare providers to understand just how impactful trauma is and how it shows up so surprisingly, so unexpectedly in so many different ways, and be curious about it, be looking for it. And that's kind of what you're naming, like in your last question, just creating an open space for people to share. Well, there was something. I don't quite know where it fits, but this happened. Whew, we're getting a lot of good stuff here. So thank you so much. Just thank you. Now I want to say, we were talking about the pelvic floor and how it's a bowl of muscles. Can you speak about who has one? I know it's sort of already been said, but we think of pelvic floor as a woman thing.
Pelvic floor is universal. And so if you have a pelvis, you have a pelvic floor. And so it really is your pelvic bones, right, are literally lined with these layers of thick muscles. And so we see pelvic floor issues in all genders, and really, and there is actually a very high, the research shows there's a very high percentage of pelvic floor disorders in transgender patients. And that's something that's being looked at, very importantly. But I have male patients with erection problems, bladder problems, perineum problems, testicle problems, low back problems peeing, pooping, having sex, having orgasm, having lots of issues. And I have female patients with constipation and urinary urgency and pain with penetration and difficulty or absent orgasm, and everything in between. And sometimes it's a local issue, or sometimes it's a hormone issue. Sometimes it's a muscle issue. Often it could be a nerve issue, even like a back issue. We see a lot of people who have back problems, and instead of it being back pain, it's actually genital issues. And so we see tons of that, and that's very ignored by the spine community. They sort of don't get taught about the genitals, so they don't ask about the genitals, and they don't really care about the genitals. We see a lot of issues, that can happen. So it's really, pelvic floor issues are universal, but unfortunately, they're also universally a little bit ignored by everybody. And so it's actually one place, I will tell you, Laura, because you said pelvic floor issues are mostly thought about as a woman's issue. Here is one tiny slice, an area that women have it a little easier. Like, there are more, they still have it terrible, and it's still really bad, and there's still not enough help and not enough research and not enough support. But male pelvic floor patients have it way worse than females do in terms of the knowledge and acceptance and sort of discussions around it. And so my male pelvic floor patients, they have a deep understanding of medical gaslighting and trauma that I think men as a population don't always have. It's kind of interesting, actually.
Yeah. And we don't want anyone to be medically gaslit or to receive less than the care they deserve. But you're naming an important point, which I wholeheartedly agree with how difficult it can be for women to get, to be heard and to be taken seriously and to be considered the expert in what's happening in our own bodies. And the more marginalized identities someone holds, the more likely they are to be dismissed, minimized, not believed, not understood, and for people not to take the time to really listen and treat them as if they matter.
It's so funny that it's not funny that you say that, but I have this thing where, because I spend so much time with people asking them questions and really just doing that detective work, that history that my colleagues don't often have time to do. Patients spell it out for you often, what's going on with them. Like, it becomes like a very clear cut, like, it started when this happened and then this, and they tell you the story, and then you're like, oh, well, you just told me the answer. Like, that's what's wrong with you. And they just tell you, and then and it's so, I report it back to them. And it's so fascinating because often people are really good judge of what's going on in their body. And yet that alone is so hard to get people to even, because so many people tell you, oh, it's all in your head. Oh, it's not real. Oh, that didn't really happen that way. And they start questioning their own sort of really ability to understand their bodies. And it's so fascinating because oftentimes I'll look at them, or I'll say, like, well, here's the things that it could be. What feels the right answer to you? What is your body telling? Like, what do you think is the right answer here? I'll tell you, patients have almost never been wrong. Like, if you come up with a hypothesis that makes sense to them, it is so, it's this like moment of, and like that is medicine in and of itself. Just having that sort of that deep connection, and you see their brains working, and you see that moment where they're like, oh my God, I just saw you touch the area that was painful and no one's ever touched it before. Just touching their pain and showing them that there's no pain next to it and there's no pain on the other side of it, but there's just pain in that one spot, makes, like, it's therapy in and of itself, of saying, oh my God, I'm not crazy. She found my pain. Oh my God, she's showing me exactly where it is. There's a word for it. There's a name for it. There's a plan for it. It's such a miracle. It's just a wonderful, wonderful thing.
Oh, yes. I've experienced that. And it's like, wow. Oh, even though there's this little inkling, I think it's this. It seems like it's this. And part of you is fighting for someone to hear that. And then someone does. And it's like, really? Oh, wow. Let the rest of us catch up. Okay. So you mentioned hormone issue, and I keep alluding to menopause. So let's get into that, because the article that was in the New York Times that you were part of is so clear. I think the headline is something like, women have been, lied to? What was
misled about menopause? It's so
yes.
funny. Yeah. It was a New York Times, wonderful New York Times magazine cover story. It's about, if you listen to the Daily has a podcast of reading, I think it takes about 45 minutes. It's a really long, very well written article, that really goes in to why are we so confused about menopause? Why did no one tell us what was happening and what was going on? And why are we all so confused? And she really did an excellent, her name is Sue Dominus, the journalist. I mean, she really did her homework. And I spent many hours talking to her, really trying to get her to understand, why this is so challenging. She talked to sort of much smarter people than me. And she did a really nice job. And so it's a really nice, you certainly can find it, for free on on their podcast, the New York Times podcast, which is very helpful.
Yes, thank you. And I'll link to that. And so what was being discussed there was this way that, this study that came out in the 90s, right? Why don't you tell us? You can talk about it much more.
Okay, so here's, so here's sort of the thing. The media sort of has gotten it really wrong, and medicine has gotten it really wrong. This idea that hormones are dangerous, hormones cause cancer, I can't take hormones, it's really bad. And it really comes, so menopause, my quote in the article is that menopause has the worst PR campaign in the history of the world, right? We all think of menopause as old ladies have hot flashes and night sweats and they go away after some time, and then you just age and you're just, then you just shrivel up and die at some point. And
but
menopause,
they also become horrible, like hags who no one wants to be around or can
you get the
stand,
hump, right?
right?
You get the hump and
Just become this like,
I think you get a cat. I think you get several cats that come with it as well. And so menopause has an awful PR campaign because it's not just hot flashes and night sweats, which go away, nor is menopause really just start after you haven't had a period for a year. I mean, you just said you had perimenopause for 10 years. I mean, it starts in your early 40s. And we have this new concept of this not feeling like myself, NFLM, not feeling like myself. This idea of like, I don't sleep as well. My brain is foggy. I'm like hot and cold all the time. I like have ear things, like my kids are talking and I want to like scratch my eyes out because the noise is driving me crazy. My mouth feels burning. I have urinary frequency and urgency. I have pain with sex now. I have no libido. There are a million, and sort of we're learning about the musculoskeletal symptoms of menopause. So you get frozen shoulder and you get all these injuries. And so it's really what is happening to the body when hormones start to go crazy. And so it's kind of puberty in reverse, right? When you're going through puberty, it's this long process, right? Where everything's changing and it's not like the moment you get your period or the moment your balls drop and your voice gets lower that you're officially in puberty. It's this really long process. It's different for everybody. Everyone experiences it differently. And so menopause, perimenopause is sort of that in reverse, where your body just starts changing and your ovaries and the hormones that your ovaries produce just start kind of going a little haywire, sometimes super high, sometimes super low, and they're really hard to capture. And there are so many symptoms that come with it. The problem is no doctor is trained on menopause. Literally less than 7% of gynecologists are trained in menopause. So if you have headaches and you go to your neurologist, they're not going to think perimenopause. If you go to your orthopedic surgeon with your frozen shoulder, they're not talking to you about menopause. If you go to your rheumatologist because you have joint pain and inflammation, they're not talking about menopause because nobody taught them. And the reason nobody taught them is because in the early 2000s, a study came out, $1 billion study came out from the NIH that said hormones cause cancer, blood clots, stroke, heart attacks, and everyone threw their hormones in the garbage the next day. I mean, it was just completely like thrown away overnight. So now you have 24 years and more of multi-generations that were never taught why hormones are important and how to prescribe hormones. And then when you go back and really look at the data, it was all sorts of gray. There were so many things that hormones did wonderful with. So, prevented fractures, which more women die of hip fractures than die of just about anything else. It prevented colon cancer. It prevented diabetes, which, as we know, is a huge killer and causes lots of problems in people. In fact, people who were just on oral estrogen, who didn't have a uterus, decreased risk of getting and dying from breast cancer. So the estrogen didn't cause breast cancer and death from breast cancer. It actually prevented it. But none of those good things made any of the headlines because good stuff never makes headlines, only bad stuff. And so you now have almost 30 years of just problematic or lack of research sort of that has gone on. And what it turns out is there were some problems with when you took a hormone therapy by mouth, right? When it could increase blood, just like a birth control pill, there is an increased risk of blood clots. But what is so cool is when you don't do it by mouth and you do like a patch through your skin or a ring in the vagina or a cream on your skin, all FDA approved products that are more bioidentical, they're more natural forms of the hormone, you don't get the blood clot risks. You don't get all these other risks that we're seeing with the oral pills. And so the benefits are enormous. In fact, there's studies that have come out that women over 65 who kept onto their hormones have wild mortality benefits and long-term benefits. And so we got it wrong. We got it wrong for so long. And now the pendulum is shifting thanks to that article in the New York Times and thanks to a lot of people on Instagram. We call ourselves the Menopause. We are really getting loud about this because the problem, Laura, is that Women are not being given the choice of what to do with their bodies. I am okay. If you never want to take hormones, that is fine with me, as long as you have an informed decision that you have made. And not everybody needs to be on all the same doses and all the same drugs, and hormones are all different. There's local hormones for the vagina that prevent urinary tract infections. There's testosterone, which can boost your libido. There's estrogen, which can help with hot flashes, night sweats, and bones. So there are many different types of hormones and ways to give them that can change the risk and benefit profile. It's not so easy that in a 10-minute visit with your doctor who has no education in this can explain at a high level. And that's why we're frustrated, because women are not being given the information so that they can make good decisions for themselves. So that New York Times article was incredible, because women can read it and say, wait a minute, I want to learn more about this. And so I actually think you can get a much better education from Instagram these days when you follow the Menopause and the right people than you can from going and talking to your trusted doctor for 10 minutes who delivered your baby, right? Unless that doctor is a menopause specialist, which is very rare to find. And so I hope that's helpful. I know it's a long-winded answer but it really forces people to say, wait a minute, maybe I don't have all the information that I need. And the doctor who told me no, or that I shouldn't be interested in it, maybe they weren't the expert.
Yes. Thank you. Thank you. Thank you. Thank you. Thank you. Thank you. Knowledge is power. Women aren't being given enough choice over our own bodies. We are not given equal choice to what men are. And that's not okay. And we're not standing for it. And so it's unfortunate in a way that one can get better information from social media, but it's also fortunate in a way that exists and it's available. So, again, I found you through Instagram. And when I read that article in the New York Times, I was like, oh my gosh, I've got to talk to her. I've got to ask her to come on the podcast. And then finding out you were local to my area, I just couldn't believe it, and even knew someone in common. So, thank you so much for the time that you have spent here today.
Oh, it's my pleasure. You got to come to our open house. We're having an open house June 9th. My new office, we just opened our brand new office in Bethesda. You should come and bring cards so we can collaborate more. This has just been absolutely an honor and fabulous to work with you.
Well, thank you. I'm on your email list, so I got that. And I have something planned on June 9th, but I'll see if I can do both, because I would love to be there and be with others who care about this and really want to spread this message. And I'm grateful to have, like you, we have a way to reach a number of people through the platform that we have. And I'm just so grateful for what you do. So I know we have to wrap up, but, are you accepting new clients in your practice or new patients? And is it limited to DC, or what's the deal?
Yeah, so a lot of changes coming. We're training people at a very high level. I'm building a team that is just the most beautiful, wonderful team you've ever seen in your life. And so please call if we can be helpful to you. Come spend the time with us, because it is time, but it is so worth the investment of your time. We will have we have some exciting things planned of some this fall. So if it is, just give us a call. We will get you on the list and hopefully get you in. People fly from all over the world to see us, to spend the time in person. It's really nothing. It is so worth it, and just amazing, to have that experience. Everyone deserves that kind of experience. And so, if you want to follow along, we have a newsletter at rachelrubinmd.com. You certainly can just follow along on social media. I'm Dr. Rachel Rubin, on Instagram, Facebook, Twitter. I'm not on TikTok, people. I'm sorry, but I'm not. And we would love to have you follow along.
Thank you so much. I'll share all of those links and the New York Times article and the podcasts in the show notes. And Dr. Rachel Rubin, thank you so much. It was wonderful to be face to face with you, and I look forward to staying connected.
Yes. Thanks for having me.
Thank you for listening to Therapy Chat with your host, Laura Reagan, lcsw-c. For more information, please visit therapychatpodcast.com.